Good afternoon. Dear doctors, welcome you all to the 42nd session of the Academica by the Academic Subcommittee of the GMOA. As you are aware, the Academica program is introduced by the GMOA to keep our medical professionals updated in knowledge and our day-to-day practice. So, we have so far successfully conducted 41 Academica lectures online, and all of them are freely available for you for further reference in our YouTube channel.
Adding to what Dr. Latilu rightly said, today marks a historic day for the academic subcommittee of the GMOA, where we have upgraded our benchmark. After being operational since January of 2023, consistently delivering high-yield CPD lectures, we are proud to say that from today onwards, we hope to expose our membership towards renowned academics worldwide in medicine. Without further ado, let me invite a consultant electrophysiologist from Teaching Hospital Karapitiya, locum consultant cardiologist, pacing and devices at the National NHS Trust UK, past editor and treasurer of the Sri Lanka College of Cardiology, Dr. Susita Amarasinghe, to introduce our eminent resource person for today and to host the program. I would also like to mention we have eminent cardiologists here with us who will be moderating this program and providing all the necessary inputs during this process. So over to you, Dr. Susita Amarasinghe, to host the program and to introduce our eminent resource person for today, beyond the Be Essential Cardiology.
Thank you very much, Dr. Rajiv Menon, for that kind words of introduction. First of all, let me, with a lot of respect, welcome our esteemed speaker, Professor Brugada. Thank you very much, sir, for spending your time for the benefit of the doctors, almost all the doctors categories in Sri Lanka, a country that you are not unfamiliar with. And I also welcome all of you, the audience, on behalf of the GM Academic Committee. And in the interest of the time, let me introduce our esteemed speaker in the formal way, briefly, before I would hand over the podium to Professor Brugada. So Professor Pedro Brugada received his medical training at the University of Barcelona School of Medicine. He is a world-renowned clinician and a specialist in the field of cardiac arrhythmias and electrophysiology and cardiology. And in a very unique way, he is one of three brothers, who all three of whom are in the same field with a world expertise on certain conditions, which I'm sure he'll be enlightening you all about. And he is currently the chairman of the cardiovascular division at the University of Hospital Brussels in Belgium. And he has previously held positions of professor of cardiology and head division of coronary disease at the Institute for Cardiovascular Disease, University of Limburg in Netherlands. And in a landmark publication in the late 90s, Professor Brugada, together with his younger brother, described the condition now well known, or very well known, especially to our region, as Brugada syndrome. And while he still have a huge interest in the condition and the spectrum of conditions, he also is a world-renowned expert in many other fields in the field of cardiac arrhythmias and cardiology. He has received many esteemed awards for his work on the specialties mentioned. He has received the highest award from European Society of Cardiology and European Heart Rhythm Association in the form of gold medal for his work on these conditions. If I am to describe all of his publications, I think the whole 2 hours we can easily spend discussing them. So while acknowledging his world-class expertise in this field, and I see this as a great opportunity for all of you, audience, to benefit from his knowledge, which is unparalleled, and we take it as a prestige that you have joined us. And I would at the beginning, thank you for giving your generous time without obviously any monetary expectations or any other expectations, just for the benefit of the Sri Lankan doctors. Over to you, sir.
Thank you very much. I'm really very honored that I have the opportunity to talk again to the doctors and particularly the general practitioners of Sri Lanka. I was there in the past, and this is one, if not the best trip that I ever had in my life with my family. We are still, remembering your hospitality, which was great. We had really, I can tell you from the scientific point of view, but also from the hospitality point of view, the best time in our life in Sri Lanka. I really thank you for that. In fact, I'm also very honored that I can talk to the general practitioners particularly, because as I started my medical career as a general practitioner. So I became a general practitioner in the Pyrenees in the north of Spain. And, I encountered there completely, like everybody in this field of, medicine, general practitioner. Now, the difficulties of being a general practitioner, because you don't have the high technologies of the specialist and you do not have the means. So you have to do it everything with your stethoscope and with your hands. And in fact, you learn that this is probably the most difficult part of the job of a doctor, is to become and to remain a general practitioner. Now, this has remained with me. And in fact, the two talks that I will give to you are purely dedicated to the general practitioner. So do not expect actually any talks about Brugada syndrome or anything like this. I will talk simply about, very simple things, being, the role of the general practitioner in clinical medicine. The first part will be, I'm going to start my screen. So let's start with the role of the general practitioner. And I also included the pediatrician because it's also important. It's the same story in the diagnosis and treatment of cardiac arrhythmias. And, as I was telling you, although I did a lot of basic research and clinical research in rhythmology, I'm going to go down to actually to very simple things. But the things, that I hope will be useful to the general practitioner to contribute to a good diagnosis in clinical rhythmology, in cardiac arrhythmias. So I put here for you 5 different things. The first one, the clinical history, the anamnesis, then the physical examination. One very important thing as a general practitioner, when should I worry and what should I refer my patient for further specialized treatment? Also, I want to tell you, and I think it's very important, that the general practitioner realizes what's going to happen to my patient when he's going to the hospital and goes to a specialized center for the diagnosis and treatment of cardiac arrhythmias. And afterwards, what should I do as a general practitioner to follow up my patient after he or she gets the treatment of the cardiac arrhythmia? Now, let's start by the clinical history. You know that everybody thinks that can talk to everybody, but this is not the truth. And in fact, as the clinical history, talking to the patient is not a technical performance. There has not been a lot of research in relation to the value of the clinical history in medicine. There has not been structure either in how to approach a patient in terms of what should I ask to a patient with a cardiac arrhythmia or any other disease, because this non-technical performance, talking to the patient, is usually also not paid for. And let's be honest, if this is not paid for, there has not been a lot of interest to do any research related to the clinical history for our patients. The second important point that we have to realize that is that talking to the patient has never been standardized. It's not at all a standardized procedure. But I'll show you that you need to apply some rules to have a good clinical history and why you should have this structure on the clinical history. Because first of all, the clinical history is the first step to decide upon further actions What are you going to do with the patient? Are you going to record an electrocardiogram? Are you going to send him for urgent treatment? Whatever. But the first thing you do, and we all do, is to talk to the patient. And we should realize that talking to this patient is actually a very important part of the whole diagnostic process. The second important point, and I'll show you that in arrhythmias, in rhythmology, the clinical history may by itself suggest a diagnosis. Just talking to the patient and asking the correct questions can help you to think, oh, the patient has this one or that one arrhythmia, or this problem or that problem, and I should be doing this or that. And in fact, even I'll show you that in clinical rhythmology, it's just as the clinician talking to patients with cardiac arrhythmias, the clinical history might even be better for diagnosis than many sophisticated tests like Holter monitoring, exercise test, or whatever you want. There's a good clinical history is the very, very much the very most important part on the initial diagnosis of our patient with a possible cardiac arrhythmia. Now, to understand what we have to ask to our patients, we have also to understand the pathophysiologic problems that are caused by the cardiac arrhythmias and how this relates to the symptoms of these arrhythmias. We have to realize that there are patients that have no symptoms at all. They have cardiac arrhythmias, but they don't feel absolutely any symptom. And this is particularly true for patients that are either very old, just think of the patient, old patient with atrial fibrillation that is not aware of the atrial fibrillation, or think on the other side at the very young patient who is born with an incessant, what we call incessant cardiac arrhythmia, an arrhythmia that is present all the time. And this individual has a high rate of about 140, 160 beats per minute all the time, but does not have any symptoms because he or she thinks that this is normal. That has been always like this the whole life. And in fact, these patients usually will come to us with other complications like heart insufficiency caused by the arrhythmia. We will talk about that later. Now, one of the most frequent symptoms that can be caused by cardiac arrhythmias are, of course, palpitations. The feeling of that your heart is actually beating fast or irregular or abnormal. And most frequently, we will have this symptom in patients with supraventricular tachycardias. We'll come back to that immediately. Dizziness, just the feeling of that you are going to lose consciousness, but nothing is happening, is really not happening, is actually also a very common symptom in cardiac arrhythmias, particularly even in bouts of extrasystoles that cause pauses because of the compensatory pause. We'll see that also. But dizziness, you remember, is not always a problem of the ears or the equilibrium. Dizziness can also be caused by cardiac arrhythmias. A very funny but important also symptom is actually polyuria. This is not a very well-known complication of cardiac arrhythmias, but some patients can present with actually as only symptom that they have got strange feeling, and then all of a sudden they have to go to the toilet, and this is actually the result of a cardiac arrhythmia that because it's changing the cardiac output all of a sudden during the arrhythmia, the cardiac output is going down. When the arrhythmia stops and the cardiac output goes again back and compensates for the deficit caused by the cardiac arrhythmia, you have more urine production and the patient has to go to the toilet. A very funny symptom, but just to remember that. Now, one of the most important symptoms, without any doubt, is syncope, loss of consciousness caused by a cardiac arrhythmia. And this, as you will not be surprised, this is much more common in ventricular arrhythmias and in bradyarrhythmias, more than in supraventricular arrhythmias. Now, there are a series of complaints also, and that depends a lot on the perception of the patient. Chest pain, fear, anxiety, dyspnea, they also can be caused by cardiac arrhythmias. And of course, the most important complication that we can have is the occurrence of unexpected sudden death because of a cardiac arrhythmia. Now, what are the clues related to these symptoms in cardiac arrhythmias. There are a few things that you can ask to the patient, and we will do that. We will structure the whole. So, what are the clues? There are several clues. First of all, these symptoms usually occur with an unexpected onset and offset. They start suddenly, without any reason, and then they stop also spontaneously without any reason. That's the typical thing. The symptoms are what we call paroxysmal, in the sense that they occur in crisis, and once they actually have disappeared, there are no symptoms between the episodes. This is not true for incessant arrhythmias. During the incessant arrhythmias, the symptoms can be completely absent, as I was telling you, because the patient thinks that this is normal to have a high heart rate, or can also just simply be present constantly. But the most typical thing is that you have symptoms in crisis with an unexpected onset and offset. And this can be dizziness, this can be palpitations, this can be dyspnea, but when they are in crisis, always think of a possible cardiac arrhythmia. The other thing is that we all think that these cardiac arrhythmias are triggered by something in the majority of the patients. This is not true. In the majority of patients, if you ask to the patient, did you find some trigger, something that actually is causing the arrhythmia? The large majority of patients, they will say no. And even some patients, they have a diary where they put when the arrhythmia occurred, when it started, when it terminated, and you'll see that the large majority of patients can not find a triggering factor, and also they cannot understand why sometimes the arrhythmia lasts for a few minutes and sometimes for a few hours. There is no clear relation. Don't worry about tobacco, coffee, certainly not stress, which is used very frequently as an excuse, as a bad excuse in terms of misdiagnosis. But there is one factor that you have to know, and which is not well known in the medical literature either, and is the relation with alcohol. One little point about this. Alcohol is, like many things, a trigger that is going to trigger the problem in people that are sensible to this alcohol. When you ask to your patients, what is the relation with alcohol, they will say, "Oh, I don't drink a lot. I don't only drink a little bit and whatever." This doesn't matter. It's a matter of sensitivity. If you are sensible to alcohol, just a little bit of alcohol can trigger a cardiac arrhythmia. While patients that are not sensitive to alcohol, they can drink a lot of alcohol without any problem. It's like, the cigarettes. Very well in our population of patients that some people that smoke, 3 packs a day, actually do not get lung cancer, and that some people that passively have been smoking, not even smoking themselves actively, but just passive smoking, if they are sensitive to the tobacco smoke, they will get lung cancer. With alcohol, it's exactly the same, because people get a little bit ashamed when you ask them about alcohol to say, "Yes, I drink some alcohol." They will immediately have the idea that the doctor is going to say, "You are an alcoholist." No. You don't need to be an alcoholist to trigger a cardiac arrhythmia. If you are sensitive, just a little glass of wine, can be sufficient for that. The most important point is also the role of exercise. We all have the tendency to actually say to our patients that when you have a cardiac arrhythmia, that exercise is not good and it is forbidden, etc. This is also not true. Depends on the type of cardiac arrhythmia. There are arrhythmias that are sensitive to adrenaline, and there are arrhythmias that are not at all sensitive to adrenaline. Let's take the case of atrial fibrillation. Young individuals, particularly well-trained sporters who get atrial fibrillation, used to have this arrhythmia during the night, during the periods of vagal activity. While when they are exercising and during, competitions, etc., they will not get the arrhythmia. While other people will actually get the arrhythmia during situations of increased adrenaline, which can be, among other things, a stress situation. Yes, this also exists. And they will never get the arrhythmia during the sleeping periods, during the situations where the vagal tone has been increased. So you have to realize that this is a very individual factor and that exercise plays a role in some patients, but not in everybody. And that there is no need to prohibit exercise immediately to any patient with a cardiac arrhythmia. There have many top athletes that have cardiac arrhythmias that they never had any episode of them when they playing, football, soccer, or when actually doing a strenuous exercise. But they had always the arrhythmia in rest. The same happens, and that's the only thing I'm going to say to you related to Brugada syndrome. You know very well that Brugada syndrome and exercise, this is not a problem, because exercise, by increasing adrenaline, is protecting the patient with Brugada syndrome against the arrhythmias. While the problem in Brugada syndrome is sleeping. When the people are sleeping, then they will die suddenly. So this is a very individual phenomenon that you really have to individualize for every single patient. Now, let's see what is the problem with the clinical history. We did many years ago, when I was still working with the late Professor Hein Wellens in Maastricht, in the Netherlands, we did a study in 223 patients that were seen by the general practitioner. And be aware that this is not a criticism to the general practitioners. On the contrary, this is actually a scientific study to actually go and get structure in the clinical history to help the general practitioner, but also the cardiologist, to make a better diagnosis based in the clinical history. So these were 223 patients that with proven cardiac arrhythmias. This was proven by the electrophysiological study that these patients had in our center. And what we look at is what happened when the general practitioner saw these patients in the consultation. And we had two groups. We had, as you can see here, 46 patients that were seen during the arrhythmia by the general practitioner, and we had 177 that were seen outside the episode of tachycardia. So these patients went to the general practitioner, this outside the tachycardia, when the arrhythmia was not present, but these ones were there when the arrhythmia was present. What was the diagnosis that was made by the general practitioner at that time? Of course, as you can see here, when the patient had the arrhythmia, almost every single patient was correctly diagnosed as having a cardiac arrhythmia, and there were a couple of patients diagnosed as hyperventilation and sinus tachycardia. But look what happens when the patient is seen outside the episode of the arrhythmia. In the large majority, actually, wrong diagnoses were suspected, like hyperventilation, sinus tachycardia, anxiety disorders, or no abnormality at all. And in only 7%, the general practitioner thought of the possibility of a cardiac arrhythmia. Why that? Well, simply, again, because there was no structure in the clinical history. The general practitioner listened and talked to the patient in a completely non-structured way. And what we tried to do with this study was to bring a structure to this clinical history. So the diagnosis was not missed because the doctors had no interest in the patient. This is not true. The problem is were the right questions asked, were the answers given by the patients interpreted correctly, was the anamnesis systematically well structured, and particularly also without no double meanings. Because, if you keep on talking to the patient and the first thing you do is actually ask to the patient, oh, you were stressed, and the patient says yes, and then you say, okay, you have anxiety. This was probably simply nothing. It was just simply that, your heart rate went up because you had stress, etc. And you do not ask any single question anymore, you will not get the diagnosis of a cardiac arrhythmia. Let's try to structure this clinical history based on the pathophysiologic mechanisms of the arrhythmias. And you know that thanks to the electrophysiological investigations initiated by Dürer and Kummel in 1967, we have been able not only to understand the mechanisms of the arrhythmias, but to come to what will be the second part of my talk today, to a complete cure of these arrhythmias, not in 100% of the patients, but in a substantial and enormous number of patients that we can cure thanks to understanding of the mechanisms. Now let's go back and use these mechanisms to go to the most essential part of the contact between the patient and a physician, which is the clinical history. First of all, we have to realize that palpitations, as I said, they are not always present, is a common symptom in patients with tachycardia and a normal heart. To feel the heart beating, you have to have a heart that is beating correctly. When actually the heart is sick, like in patients with ventricular tachycardia after myocardial infarction, or patients that have an enormous dilated heart because of congestive cardiomyopathy, the patient will not have palpitations as a symptom. He might have syncope, sudden death, he might have no symptoms at all or go into cardiogenic shock, but palpitations is not the common symptom of these patients with an abnormal heart. So palpitations, in fact, in some way are good news because the heart usually will be good mechanically and will be typically a symptom for patients with supraventricular tachycardia or in the patients with ventricular tachycardia and a normal heart, a completely mechanically normal heart, what we call still idiopathic ventricular tachycardia. Now, once you have these palpitations in the clinical history, if the patient tells to you, my heart starts beating fast, you have to actually, of course, ask a series of characteristics of these palpitations. The other thing that you will ask is about how this starts, how this terminates. We will ask, of course, if there are some triggers, initiating factors, and we'll also ask for other symptoms, not only the palpitations, but whether the patient has other symptoms related or associated with these palpitations. Now, let's get a little bit into electrocardiography and pathophysiology of the supraventricular arrhythmias. Now, when you have a supraventricular tachycardia, you can have a relation one-to-one between atrial activity and ventricular activity. We'll come back to that with some examples, Or you can have a completely dissociated activity because you have actually a variable AV relation, an atrial tachycardia with more P wave than QRS complexes, atrial tachycardia with AV block, then you have more P wave than QRS complexes. But when you have a relation one-to-one between P waves and QRS complexes, the P wave can be positioned basically into two positions. Can be together with the QRS complex, then you will have a simultaneous contraction of the atria and the ventricles. And what's happening then, instead of the normal sinus rhythm, now you will have that this is contracting simultaneously atria and ventricle, but of course the valve, mitral and tricuspid valve at the moment that this happens is closed, so that you will get this blood going back to the superior vena cava, and this is causing the sign that we call the frog sign, frog positive. That means the patient will feel also palpitations in the neck. When the P wave is later after the QRS complex, then this is what's happening. The tachycardia is now contracting, the contraction of the atria and the ventricle is not together, but one after each other. And then you will not have this phenomenon of contractions, of pulsations, palpitations in the neck, and we call that the negative frog sign. Okay. So what is now the pathophysiology of this? What is this happening? Now here you have an example now of a heart, a model of a heart with the right atrium, the left atrium, then here we have the right ventricle and the left ventricle, the conduction system of the heart, the AV node, the bundle of His, the bundle branches, the Purkinje system. And I have put here 6 different types of tachycardia. We have here a tachycardia from the right atrium, a tachycardia from the left atrium, 3 is an AV nodal reentrant tachycardia. All of them are reentrant arrhythmias here, going around in the AV node. Then we have here, number 5, this is a very rare arrhythmia, but you have also to know that this exists, which what we call bundle branch reentry. So a circle, the impulse circulates between the bundle branches and causes a sort of ventricular tachycardia. And this is here the classical ventricular tachycardia. And finally, we have here a tachycardia utilizing an accessory pathway, atrioventricular accessory pathway. Well, you see that the circuits are completely different. These circuits here are located into the atrium, do not need the ventricle at all. The one in the AV node is actually in between the atrium and the ventricles, does not need the ventricles or the atrium at all. And here, this one is a circuit that requires conduction to the ventricles and then back to the atrium, so it utilizes all the heart. And you see here that the ventricular tachycardia and the bundle branch reentry tachycardia do not need the atrium at all. So this is the circuits, determine the position of the P wave, as we will see. You have it here. So let's see these 3 electrocardiograms. We have the position of the P wave in 3 different situations. Here, this one, the P wave is actually in the QRS complex, is inside the QRS complex. This is typical of course, AV nodal reentrant tachycardia. So when you have the circuit here, the P wave is actually retrograde, and at the same time, the ventricular activation happens. So there is simultaneous activation of the atrium and the ventricle, and that's how you get this P wave together with the QRS complex. Typical for AV nodal reentrant tachycardia. And we'll come back to this. AV nodal reentrant tachycardia is typically an arrhythmia of young females. Here we have a P wave, look at this very nicely here, after the QRS complex, and usually around 140 milliseconds. There's 3 literal squares and a half after the onset of the QRS complex. And this is typical for the tachycardia that utilizes an accessory atrioventricular pathway, like in the Wolff-Parkinson-White syndrome. This one, we have it here. So this is this activation of the ventricles, and after the ventricles, the P wave. So here in AV nodal reentrant tachycardia, simultaneous, together, atrium and ventricle. Here, not. First the ventricle, and after activation over the accessory pathway, the atrium. So the P wave after the QRS complex. That's a different position. And here even you have one, which are very special tachycardias, either an atrial tachycardia or the same accessory pathway, but if conducts very slowly, if it conducts very slowly, actually we will have a P wave, not 140 milliseconds, but even more than 200 milliseconds after the QRS complex. This is typical of a slow accessory pathway. So this is coming here, and now instead of conducting fast, it's conducting slow, very slow, and the P wave comes very late. Comes back, P wave very slow conduction, and P wave very late. When it's a fast accessory pathway, it comes here, fast conduction, P wave. So that's what determines the position of the P wave in the different supraventricular tachycardias. Now, here we have some schemes to show you that nicely. This is the AV node. You see here the sinus beat. You know that what happens in AV nodal reentrant tachycardia is that these patients have 2 pathways in the AV node, the slow pathway, we call it, and the fast pathway. During normal sinus rhythm, which you see here below, the P wave, the PR is normal because conduction takes part over the fast pathway. The slow pathway just does not conduct more until here. And when you have a premature beat, you actually will block in the fast pathway. The conduction happens over the slow pathway. That's why the PR interval prolongs. And then, because this has blocked, actually the activation can go around and start the tachycardia that you see here. So extrasystole, long PR, and tachycardia, and the P wave is in the QRS complex, typical for AV nodal reentrant tachycardia. Now, you can see it here nicely if you like. You see here the impulse coming down and activating the fast pathway and the slow pathway. That's a nice example, as illustration of the right atrium, the left atrium. This is the bundle of keys, the bundle of branches, and that's the AV node, a complex structure, much more complex that I show you. And you see here, the impulse will go down to the ventricles, of course, and actually after activation of the ventricles, nothing happens. But if a premature beat comes and it blocks in the fast pathway, then it will come down to over the slow pathway, will come back, and then we'll start the activation around here like this. We will have this circuit activating the atrium and the ventricles simultaneously. Okay. Now that we know that the position of the P wave can cause these palpitations in the neck also, and we have then this so-called frog sign, we can utilize this to understand a little bit the possible problem of our patient by asking a few questions based on the palpitation. So the patient say, I have palpitations. Then the first question you ask is, what happens? Your heart starting to go all of a sudden fast? Yes, it goes fast. It goes very fast. Do you know how fast it goes? Most patients will say, no, I have not have the opportunity to measure. Maybe another one tells you, yeah, I have an old watch, and the watch said that was 180 beats per minute and so forth, whatever, but you know that they are fast. The heart rate accelerates. So then you are to the patient, okay, you have rapid palpitations, good. Then we have three possibilities. Either the heart rate is going up and is fast and regular, continuous. And what I used to do at the moment is actually to tap on the table like this, like a tachycardia. And I say, you see this is regular. Is that like this? Or is it irregular, like that? Pop, 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 pop. So simulating atrial fibrillation. When the patient says to me, no, it's irregular, fast and irregular, then my suspicion will be that the patient has, of course, atrial fibrillation. It could be an atrial tachycardia with variable AV conduction, but depending upon the age of the patient, etc., and also the most common diagnosis will be rapid irregular palpitations, will be atrial fibrillation. On the contrary, if the patient has rapid palpitations, but they are regular, constant, then we will ask to the patient, do you feel the palpitations in the chest? And they will always say yes, because they feel the palpitations in the chest always. Say, do you also feel them in the neck? And, if the patient says to you, yes, I feel it in the neck also, like here, palpitating in my neck, then we have the frog sign is positive. This is typical of AV nodal reentrant tachycardia. And if the patient is not only having rapid, regular palpitations with a positive frog sign and is a woman, I can tell you that this is 95% of the time is going to be AV nodal reentrant tachycardia. And you see, only with the clinical history, no Holter, no exercise test, even not a single electrocardiogram, you have 90% security that your patient has AV nodal reentrant tachycardia. Only talking to the patient, you have a correct diagnosis 95% of the time. But you have to ask the correct questions, okay? If the patient has rapid, regular palpitations, but the frog sign is negative, then of course there are several possibilities. It can be almost everything. It can be an accessory pathway, like in the Wolff-Parkinson-White syndrome, the one with the P wave after the QRS complex, not in the QRS complex, causing the frog sign. Can be an atrial tachycardia, can be also ventricular tachycardia. There is a second group of patients, the ones that say to you, no, my heart is not beating fast. I just feel it's beating even slow, like if it stops and starts again. Of course, at that time you are going to think of extrasystoles. And the extrasystoles, again, you might find that in some cases the patient says that feels that beat also in the neck, like beating in the neck, which is a form of slow frog sign. This is caused by ventricular premature beats that cause the same phenomenon. You have normal sinus rhythm, and all of a sudden, boop, there is a simultaneous activation of atria and ventricle for one beat, and the patients can feel that in the neck. This will tell you that these are most likely ventricular premature beats, but if he has no frog sign with these slow regular palpitations, then it could be atrial extrasystoles, but also ventricular premature beats. But you see that just with these simple questions, you already have an idea. And in this case of AV nodal reentry tachycardia, almost a certainty that you got a diagnosis of a cardiac arrhythmia and also the mechanism. Thus, that means the frog sign is a very important part in the clinical history, as for the neck, but also if the patient is at your place during the tachycardia, please have a look to the neck, because during the tachycardia, if you see the pulsations in the neck of the jugular veins pulsating like a frog, a rapid frog, then at that time you are also seeing the frog sign, not only asking for it, you are seeing the frog sign, and this is also helping you in the diagnosis. Now, let's talk a little bit about the mode of onset of palpitations. I said to you that they have an abrupt onset, yes, but be careful, not always, because in fact, arrhythmias occurring during exercise may not be perceived as abrupt. So the patient is very different if the patient is sitting, has a heart rate of 60 beats per minute, and all of a sudden goes to 180. There is a big difference in heart rate, and the patient will feel that. But if you are now in your bicycle and you have a heart rate of 130 because of the exercise, and you go to 160, 170, that might not be felt as a sudden acceleration. The patient might think that this is because of the exercise. So be careful about the question. Depends on the circumstances, the moment that the arrhythmia occurs. And also be aware that not only a cardiac arrhythmia, but also sinus tachycardia can actually be perceived by the patient as a sudden onset. And I believe we all have experienced this phenomenon, that when you get scared for something, for instance, and your adrenaline goes up, then your heart starts beating fast, and it's a sinus tachycardia. So that means that the fact that it starts abruptly does not means immediately that this is a cardiac arrhythmia. Can also be a sinus tachycardia. And the same when you have someone having an arrhythmia during exercise, the patient might do not feel that as an abrupt onset. The same happens with the termination of the palpitations. We always, have learned that when you have a cardiac arrhythmia and it stops abruptly. Yes, that's what we see on the electrocardiogram. But the perception of the patient can be different. Because of adrenaline going up during the tachycardia, the patient might have a sinus tachycardia at the termination of the arrhythmia, and he might not perceive this termination as abrupt. He might say, no, it goes slowly down, because the sinus tachycardia is going down also later on. So it's not always the rule that an arrhythmia terminates abruptly, yes, but that the patient will perceive this as an abrupt termination. It depends on the circumstances, again. Initiating factors. I mentioned already the alcohol. Remember that you don't need to drink a lot of alcohol to trigger a cardiac arrhythmia. If you are sensitive to it, a little bit is sufficient. I mentioned already the relation with exercise, which is not always true, that all cardiac arrhythmias are related to exercise. On the contrary, and as I mentioned also, vagal induced, the ones particularly of athletes, atrial fibrillation during the night, Brugada syndrome, sudden death during the night, that this is not also related to any adrenaline. And in fact, we have to always ask about the effect of drugs. particularly, and I'm not going to discuss that, but you know very well that some drugs can normally some intervals on the electrocardiogram, like the QT interval, produce a long QT syndrome, drug-related, and cause cardiac arrhythmias like what we call torsada de pointes and sudden death. But one important thing, when you are to your patients, do not expect too much. The majority of patients will say, no, I have not found any relation with anything. And particularly in young women, we have done a lot of studies to see whether, the menstrual cycle had a relation with the cardiac arrhythmias. Don't think that this is so. There is, in the majority of cases, they might think that there is a relation with the period, but once you ask them, to these patients, to make a diary of the cardiac arrhythmias, you'll see that there is no hormonal factor playing a role in the initiating of cardiac arrhythmias in the majority of women, but that they come whenever they want. Now, associated symptoms. I mentioned that the different types of symptoms. We said that it can go from no symptoms to sudden cardiac death. Remember this slide. Now, this is what happens with some severe cardiac arrhythmias, and you see here there's the initiation of a cardiac arrhythmia that leads to sudden drop in blood pressure. You see here the carotid pressure that of course is causing syncope, and because now we have someone doing cardiac massage, we see this blood pressure going still up. Otherwise, if this continues, will cause the sudden death of the patient. Of course, syncope is actually one of the most worrying symptoms in any patient. And syncope is a medical emergency. If you do not have a diagnosis of syncope, you have always to, in some way, think of protecting your patient. Protecting your patient means that if someone has syncope, even when you think that is a vasovagal syncope, be, as a general practitioner, protective of your patient. Syncope might be the first and the only warning before sudden death. Now, let's go just for a second to Brugada syndrome. We have now thousands of patients recognized with this disease over all the world, 10,000, maybe hundreds of thousands of patients by now. But what we have seen is those who suffer cardiac sudden death and survive the episode because of resuscitation, when we go back to the clinical history of these individuals, 1 out of 2 had never any syncope or any symptom before sudden death, and 1 out of 2 had syncope, and that syncope was actually not further diagnosed. There was a syncope in the clinical history, and next time the patient, instead of developing a syncope, developed sudden cardiac death. So beware that it can be the only warning sign of a possible sudden death in the future. And okay, I know the most common cause of syncope in young individuals is vasovagal, but don't forget that also syncope is the 1 out of 2, actually the only warning symptom for sudden death in young individuals also who have Brugada syndrome, and Brugada syndrome has not been recognized. Now, the same that we actually have said for the clinical history can be applied to the physical examination. Of course, as a general practitioner, you have seen usually the patient will come to you outside the episode of arrhythmia. But if we actually have the good luck that we see the patient during the arrhythmia, even without an electrocardiogram, if you do a physical examination, you might think of a diagnosis. Obviously, if the patient has a variable blood pressure, the heart sounds are variable, the arterial pulsations are irregular, and you don't see pulsations in the jugular veins, the common diagnosis will be atrial fibrillation. On the contrary, if the patient has regular fast pulsations with a fixed blood pressure and heart sounds, and you see in the neck the frog sign, that is palpitating in the neck, you are facing a patient with AV nodal reentrant tachycardia, even before you take your ECG. And if this is the same, but you do not see the frog sign, you either have a patient with an accessory pathway, Wolff-Parkinson-White syndrome, or a patient with an atrial tachycardia. And when you have a patient with ventricular tachycardia, with dissociation between the atria and ventricular events, you'll see the blood pressure is also varying, the heart sounds are also varying, but the arterial pulsation will be regular instead of irregular, like in atrial fibrillation. And if you look at the neck, you might see from time to time what we call the cannon waves, which is the moment that there is the ventricular tachycardia and the sinus rhythm on the top, and at the moment that they are simultaneous, from time to time, you'll see one pulsation, a cannon wave in the neck. This is very simple. It's just a matter of measuring the blood pressure, listening to the heart, taking the pulse, and looking at the neck. And you can have already an idea of the diagnosis. So, when to refer my patient? Well, I think that you should always try to, again, be protective to your patient. And once you suspect a cardiac arrhythmia, the patient, should be seen by a cardiologist, an electrophysiologist, depending on the situation, to really get a correct diagnosis and treatment. Because, as I was telling to you, nowadays we actually are able to cure the majority of patients with these cardiac arrhythmias. So I'm just going to show you something that you know, probably, but just to illustrate what happens to a patient that has an atrial flutter. You have suspected the diagnosis because of palpitations, in this case, regular and without a frog sign. And the patient I send to the cardiologist, electrophysiologist, and he performs an electrophysiological study and then says, well, okay, we actually are able to cure this arrhythmia using catheter ablation. And as I was telling you, the majority of arrhythmias can be cured because with this, I have here the list of all the arrhythmias that we can treat with either radiofrequency ablation or cryoablation, instead of burning, actually freezing the area of interest. And if you look at this, you have here the flutters, a typical flutter, and what we call a reverse flutter. What is this? This is the right atrium. Here we have the left atrium with the pulmonary veins, where we ablate for atrial fibrillation. And what's happening? There is a circuit going around the atrium, the right atrium, like this, in this case, in the typical flutter, and on the contrary, going actually here clockwise and here counterclockwise. This is the typical atrial flutter. And the area of interest in both cases is here. This is what we call the isthmus, around the coronary sinus, the area between the inferior vena cava and the coronary sinus. Here we have the area of interest, the area of a slow conduction in both cases. So what we do, here is a model of the heart, and what we do is put a catheter around the right atrium with a lot of electrodes, as you can see, these little metal things here, to actually follow the activation of the heart. And at the same time, we put catheters, of course, to do the ablation. We do that from the groin with local anesthesia. That's how it looks in the X-ray. You see here the catheter in the right atrium. All these black dots actually here, these are all the electrodes that we use to measure electrical activity. And here we have a catheter with a thick electrode here, which is the catheter that we will use to ablate actually the area of interest, the one I show you, which is located here. This catheter is now a little bit further. And you see here the area of interest. This is the mouth of the that's the tricuspid valve, the inferior vena cava here, and that's the mouth of the coronary sinus, and that's the isthmus. That's what we call the isthmus. That's the area of interest. I'm getting sort of confused. Here is the coronary sinus. This is the isthmus. And there you see now, you can see that area here. This is the isthmus. That's the right atrium. We have now given some contrast. You see still the catheters, the ones that we use. to simply record the activity. You see here the flutter, the patient is in flutter, going here, you can see the flutter waves here when the atrioventricular relation changes. And now what we will do is actually simply measure the electrical activity, see how this is going around these electrodes, confirming the diagnosis of atrial flutter, and will ablate, will destroy, actually, will burn this area, in this case, a very long isthmus here. We will go point by point, burning, in this case, this area to simply see what happens, which is that the flutter here, it's actually going 2 to 1. This is a P wave, 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 and you see one QRS complex every 2 ways, 2 to 1 block, and all of a sudden, during the radiofrequency ablation, boom, the patient will regain sanity. So this is actually the result of a good clinical history that brought you to a certain diagnosis of a cardiac arrhythmia because of the characteristics of the clinical history. You might suspect an AV nodal reentrant tachycardia or another arrhythmia. This is confirmed by the cardiologist, electrophysiologist. The appropriate treatment will be given, and at that time, you will have done, as a general practitioner, what is our job, which is a correct diagnosis, and the people that are taking care of these high-tech procedures will do the correct treatment, and the patient will be sent back to you. Now you can say, well, what is that in reality, what is happening? I just have one slide here. And this is illustrating, one of our nurses that is behind the telephone, and a certain Mr. Jansen in Belgium is calling, and, he's saying, oh, no, I would like to have actually a consultation because I have palpitations, and even the nurse will ask, okay, I have talked to the doctor that you have palpitations, and you told me already that you felt the frog sign, so we have scheduled you for an ablation next week. You will be cured, no problem at all. So that what I'm telling to you, that with a good anamnesis, with a good clinical history, even a nurse that is interested in this area, knowing these little details of the clinical history, you can make a diagnosis, and you can actually refer the patient appropriately for a treatment that, as I said to you, in the majority of cases will result in the cure of your patient. So that was for the first part that I want to tell to you, to remark again the importance of talking correctly to the patient, to actually not forget, that the clinical history is the first step to a correct diagnosis of a cardiac arrhythmia. I thank you for your attention for this first part, and if you like, we can have some questions, and then we'll go to the second part related to the new developments in cardiology. Thank you.
Thank you very much, Professor Brugada, for that very comprehensive and very enlightening discussion, starting from the very basics to make it quite simple for a young doctor
to understand the significance of the clinical presentation of a patient, so that they can track the patient into the right pathway, ending up with a successful outcome for the patient. And your last slide was very nicely summing it up all together, the importance of analyzing these basic clinical details and how it's going to reflect on long-term patient care. Thank you very much, sir, for that excellent first segment of our program talk. We have asked our audience to forward any of their questions that they have. We have received, I think, 1 or 2 questions. May I present to you the first question we have received, which is actually on the QT interval variation. And I'll read the question that we have received from the audience. So this is about a patient whom one of our members have seen, a 32-year-old trained athlete presenting with complaints of palpitation and shortness of breath while running a 5 km race. And the clinical examination has been normal. Otherwise, the ECGs, the first 2 ECGs, I would assume, which has been carried out quite immediately afterwards, has shown a corrected QT interval of 465 and 470. And his question is the subsequent ECG that had been carried out about an hour or two has shown almost a normal QT interval, a corrected QT interval of 430. So his question is, how is the corrected QT interval varies and the significance of it?
That's a very important issue because you know that the QT interval and the QTC are not a fixed, they do not have a fixed value. And the main problem that we have is that people with the long QT syndrome, real long QT syndrome, a hereditary form, which has been proven even with genetic studies that they have a mutation, may have a normal QT interval, and that some people without the long QT syndrome and no genetic disorder may have a borderline QTC interval. So there is an overlap. If you put the curves of the QTC together of the normal people and the people with the long QT syndrome, there is an area of overlap between the two. People with the disease that have normal QTC and people who are normal that have what we call a little bit prolonged QTC interval. So then it comes to the point that you have to really consider here for that individual person, that athlete, you have to consider the family history. Is there certainly a family history of long QT interval? Secondly, you have to consider the variation, as you said. If you see that in the Holter monitoring, the behavior of the QT interval is normal, okay, then it's very different that if you see that, for instance, during exercise is not shortening. And when you are in doubt about that, we perform what we call an adrenaline test. And we look at the response of the QTC during the recording of the electrocardiogram. We give adrenaline. This test has to be done in hospital, of course, by experienced people. And then we look at the behavior of the QTC and the QT. The normal response of the QT is that with adrenaline will shorten. And actually there are parameters and there are measurements, as you know very well, that as cardiac electrophysiologists we use to define what is a normal shortening versus no shortening or prolongation. Typically, in some individuals with a long QT syndrome, you will see that the QTC does not shorten appropriately. It becomes the corrected QTC becomes longer and longer the more adrenaline you give. This is not normal. So when you are in doubt, we have some tips to look at that. But the QTC that you mentioned is just borderline, and it's not 460, 465. And as you know very well, the other thing is be careful with the measurement of the QT because it's very tricky. It's very difficult to measure the QT, particularly in young individuals who have sometimes a U wave also. You have the QT, and sometimes after the T, you have also a U wave. And what is your machine measuring? Is measuring the QT or is measuring the QU? So my point would be very, very simple. Such a patient who is actually complaining of palpitations, you have let's say, borderline or possibly abnormal finding, should be referred to a cardiologist, electrophysiologist, to actually undergo the necessary test, because the palpitations have also to be studied. Is this patient suffering from atrial fibrillation or ventricular arrhythmia? So there are two parts, the palpitations and the QTC. And I think that this is a typical example of a patient that you, as a general practitioner, should send to the cardiologist, electrophysiologist for further investigations.